Much for joining this event today on gender-based violence. I'll soon hand over to my LIDC director, Professor Claire Heffernan, but first just some housekeeping. First of all, we are recording this event for your information. And if we can ask you to please keep your microphones muted and your cameras off during the presentations. After the presentations, you will be invited to ask your questions. So you can use the raise hand function in the panel on your right. And I think that's all from me. So I'll hand over to Professor Claire Heffernan to introduce the speakers.
Great. Welcome everybody to our event, 16 Days of Activism, No Haven at Home. And I think most of you will be aware that these 16 Days of Activism against gender-based violence is an international campaign that takes place every year from the 25th of November, the International Day for the Elimination of Violence Against Women, and runs to December 10th, today, Human Rights Day. And here at LIDC, we really recognize the importance of these 16 days in forging global awareness, and their need can't be understated. You know, while many of our members at LIDC will be familiar with these statistics, they certainly bear repeating within the context of COVID. Globally, even before the pandemic began, 1 in 3 women experience physical or sexual violence, mostly by an intimate partner. Since COVID, data shows this dramatic rise in calls to domestic violence hotlines and helplines across many countries across the globe. And despite this direct link, in some countries, resources have had to be diverted away from violence against women to immediate COVID-19 relief. So we have we are absolutely delighted with our panelists today. They come from 2 very different perspectives. Our first speaker, Professor Jean Feder, OBE, qualified as a doctor at Guy's Hospital Medical School and has worked as a GP for 32 years. And over this time, Jean's focus has really shifted from early interest in chronic cardiovascular and respiratory conditions to domestic violence and abuse. Since 2017, Jean has co-led HERA, which is Healthcare Responding to Violence and Abuse, with a colleague, Lorraine Bacchus at LSHTM. And through HERA, he collaborates with a range of colleagues across the world, from Brazil to Palestine to Nepal, to develop and evaluate healthcare responses to violence against women. And Jean, in 2013, was awarded an OBE in the Queen's New Year's Honors List for services to healthcare and victims of domestic violence. Today, Professor Feder will speak about HERA and the important work that he does there. Welcome, Jean.
Thanks, Claire, for that introduction. And so what I'm going to do is talk about HERA, and I'm going to use a presentation to help me do that. It's a privilege to have been invited to do this work here in front of you at LIDC. I was just saying before in the introduction that what incredible work LIDC does, bringing together so many different organizations and players around international development. So this is really a story, which I'm going to tell fairly briefly, about how HERA developed and what we've done so far within HERA. This first slide is just simply presents all the symbols of all the partners who are involved. You may notice there is a black circle over the University of Bristol's logo. That's because it turns out that the logo includes 2 symbols of slave-owning families, and the University of Bristol is in the process of now rethinking its symbols, and in the meanwhile, we thought a black dot was probably the best way of covering that. So Claire's already said that the statistics, the epidemiology of violence against women, of gender-based violence, bears repeating and repeating and repeating. It's an epidemic on a very large scale, and it affects all regions of the world. And the actual experience of domestic violence and gender-based violence has profound health impact, particularly mental health impact, but also long-term chronic physical ill health. The goal of HERA, Healthcare Response to Violence and Abuse, is to address that, and that's with partners in Brazil, Nepal, the occupied Palestinian territories, and Sri Lanka. And the focus is very specifically on the health system responses to violence against women. So where we know that there's a lot of good work, and there has been now for decades, around community responses to gender-based violence, both well, particularly in the global south, also to some extent in the global north. But the healthcare response itself has had less attention and less evidence about what's effective in helping healthcare systems provide a safe space for disclosure of violence and supporting survivors. And the goal in doing this is to work through the research capacity and prowess and skills of researchers in the global south. So the focus of HERA is very much on a collaboration to build up and to strengthen the ability of collaborators in the global south to do research around the healthcare response to violence against women. And the key focus, which I'm going to talk about, is the development of interventions within healthcare settings, piloting those interventions, and looking at their feasibility and acceptability. And Poonam, who's going to speak after me, is actually a key collaborator in this work in Nepal. We're very interested and ambitious about trying to use the findings of the research we're doing at the level of policy, and also to leverage and to catalyze new funding for further research in the global south on violence against women. How did we get here? Sounds like a talking head song for those of you of a certain generation. Well, I think it's interesting to know that the trajectories that the researchers go through to get to, for instance, working with a global collaborative group. So for me, that trajectory has very much been around initially working around the healthcare response within the UK and indeed within the global north. And that's been a really good collaboration between the London School of Hygiene and Tropical Medicine and the University of Bristol, and Lorraine Backus, who's my co-director on HERA, has been a key player in that. And we had grants from the UK's National Institute of Health Research Programme looking at the healthcare response to domestic violence, as it's called here. And that was a stepping stone for me to do work with collaborators in the global north, and then began to make contact with, and some kind of low-level collaboration, if you like, with colleagues in the 4 countries that we formed this global group with. So this wasn't done from a kind of blank sheet of paper. It was done from some knowledge already of what the interests were of potential collaborators. And I think that's key, because developing collaboration does take time. We were also then blessed with the Medical Research Council's Global Challenges Award to work with collaborators in Brazil and Palestine. And then I think for me, a key step was working around the WHO guidelines of responding to intimate partner violence and sexual violence against women. I chaired that development group, and it was my first, if you like, systematic contact with researchers and activists in the global south, and made me aware of the complexity and the challenges of trying to develop interventions that were context specific and appropriate in those settings. And that was sort of gave me the kind of energy to think about how to put together a group. What I'm going to talk about first, and don't worry, it'll be relatively brief, is what I think is the core ethos of our group's work, of HERA's work, which is actually strengthening research capacity. It's not that the research itself isn't an important end in itself, but it's also a means to engage researchers in developing their capacity. We don't use the word capacity building anymore. A couple of years ago, some of our collaborators said, we don't like the building idea, because it's like you're starting from ground zero. So we talk about capacity strengthening. And the goal here is to build new research relationships. And it's to then also take current relationships that we have and strengthen them. And then to look at the research capacity across whole healthcare and academic systems. And this is the sort of some of the detail about what we're trying to do, because where the different countries are and their universities and research groups are in terms of their skills and capacity does vary from country to country. And we've tried to do something that's specific to each country. And these are the elements of that. This may be familiar to most of you who are involved in development research. You know, everything on one hand to enhancing research skills, to actually then working on the kind of research infrastructure that you need to do good research, which is around research governance administration, finding the resources for doing that, building up the collaborations and the relationships, and then also something about the research profile, helping our collaborators progress within their institutions and within the higher education networks into positions of some security, which is quite difficult in the research and academic world actually globally at the moment, but it's particularly challenging in the global south. This you could call it the neo-colonial model for the relationship, the power relationship and research collaboration between high income and low and middle income countries. It's cartoon-like in a way, and we hope it's not really current anymore. We were going for something more ambitious in the first instance, which was looking at mutual learning and mutual collaboration and learning from the research and the insights and knowledge that were already held by our research collaborators. In the course of the last couple of years, we're challenged to do something perhaps a bit more radical than that, which is to decenter the key role of the UK in this relationship. And maybe in the Q&A we can discuss how far we've gone down that road. The money obviously comes from the UK, it comes from the National Institute of Health Research, which is like top sliced money from the NHS budget. How does power evolve if you're really trying to decenter it and create this a more mutual power relationship? That's certainly something we're trying to do within HERA. And I have some concrete examples beyond the rhetoric. For instance, our ethics training is delivered by the Brazilian team, who have incredible expertise around that. The topic guides and some of the innovation around, for instance, questions around LGBTQ came from Nepal, came from Poonam actually. And our early career research group is run by early career researchers from our partner countries, from the global south countries. So we're trying to, in a concrete way, make this happen. Just to say something about the research objectives, they're very similar in the different countries. All of them are focusing on developing interventions within primary care and sexual and reproductive healthcare settings. We're piloting them. We're in a couple of countries looking at cost effectiveness through modeling. It's mostly about feasibility and acceptability. We're not running fully powered trials in any of these countries. And each country has developed its own intervention, but very much linking across. And there are some real common features in all four HERA interventions. How are we doing? Well, we've got, I think, really good research teams in the countries. We have 3 PhD students who are making excellent progress. We've managed to engage the stakeholders, maybe not as quickly as we wanted, but we've engaged them now. We have a good systematic review of these kind of interventions in sexual and reproductive health services, which is almost ready. The primary research which we do to inform the interventions is more or less completed in the countries, and the intervention development is more or less completed. And we're now starting to run the interventions and pilot them. We have some traditional academic outputs, which is part of everybody's requirement as an academic. And I'm going to conclude fairly quickly now, as I'm aware that we want to have good time for discussion, but here are just some reflections which may be of interest to you as an audience. Some of the things we've learned so far. We're very keen on using rapid analysis methods to inform interventions. It means that even before you publish your interview, say with survivors of domestic violence, or violence against women, or service providers, you use the data and that initial analysis to inform the structure of your interventions. You move more quickly than you do, when you're submitting a paper for peer-reviewed publication. We've learned, and we've kind of learned this from the UK as well, that implementation is not a binary, first you're implemented and then first you're not implemented, then you're implemented. It's very much a continuous and interactive process, and trying to collect data alongside the whole implementation process is crucial. We have a really strong social scientists in our group, and we're really trying to understand some of the underlying mechanisms whereby implementation happens or doesn't happen, and how context works. We struggled a bit with blurring the intervention work from the evaluation work. And if we were doing a trial, this would be quite important to have a real wall between them. But in a pilot context, there's actually much more movement between intervention and evaluation. Happy to talk more about that in the Q&A. We've now integrated quality of life measures into our work because we want to do some economic modeling. An important message is that we want to avoid this sort of passive victim, active agent kind of dichotomy when looking at the response of survivors to violence. Now, this isn't an issue just for low and middle income countries. It's true in the global north as well, to try to understand different forms of agency when you're surviving violence. And that's more nuanced than just seeing people in a simple victim kind of framework. Talked already about getting key stakeholders involved very early on. And then just a finding that in the pilots so far, very few women want to accept referral to external support outside, if you like, the healthcare setting. So we're really now working with trying to provide some of that support within the clinic setting. We're reaching out to other research groups and indeed with other global players like UNFPA. Again, Nepal is very good at bringing together different collaborators. And, we've had some challenges. There was no funding for the first 6 months, which if you're a global north academic, you can maybe get away with. If you're working in the global south in a university that doesn't have any buffered funding, then that's really difficult. NHR is thinking about what it needs to do about that. The contracts were a dog's dinner, if I can say that. We had to also struggle to get payments in advance to our partners rather than 3 or 6 months in retrospect, which is what the universities particularly wanted, again, because of the financial precarity of higher education institutes in the global south. And then inevitably, perhaps the civil unrest and political violence in at least 3 of the 4 countries has been a problem and a challenging. And then this happened. And of course, we will talk about that more in the Q&A. That's had such an impact on both the services and the research, although it's incredible how the HERA teams have actually risen to the challenge of COVID and the public health and clinical impact of COVID. This is what we're hoping to do. We're hoping to move on to apply to be a global health unit. We want to extend the collaboration to other countries, and we want to really work at getting our partners holding grants. So the grants aren't just held by the UK collaborators, but are actually held directly by the partner countries. This is the usual disclaimer. I'm not speaking on behalf of the UK government or even NIHR. Thank you to our wonderful global program advisory group and to the fantastic HERA teams. And that's a lot of names, so I'll just leave you with this picture instead.
Okay, thank you. Thank you, Jean, for that. That was a really important overview. And I'm sure there'll be a lot of questions. So our next speaker is Dr. Poonam Richall. She's a medical doctor and researcher with more than a decade of experience in conducting research on violence against women and gender intersectionality. She's currently working on a project funded by the Research Council of Norway on developing an intervention to improve the safety of women in antenatal care settings in Nepal. And she's also a PI on a study that explores the experiences of lesbian, gay, and bisexual people in Nepal. And this is a collaborative study between Linnaeus University, Sweden, and Kathmandu Medical College in Nepal. So today, Poonam is going to take us, we'll discuss the prevalence of gender-based violence and interventions to prevent and respond to this issue in Nepal. Welcome, Poonam.
Yes, thank you. And I'm also co-investigator, with HERA team in Nepal. So I just wanted to add to that. And today I'll be speaking more about Nepal and gender-based violence in Nepal, with a more focus on violence against women, actually. And I'm not doing any presentations, so I'm sorry for teasing your patience hearing me. So Nepal is, and luckily I'm not talking about Mount Everest. So Nepal is a small country. We're between China and India, with 30 million population, multi-ethnic, multilingual, and multi-religious country. If we talk about women, although there are lots of transition in terms of education of women, still more men than women have completed their higher education, and there is there is this rural and urban divide and disparities come because of being from a rural area or being from an urban area. So and then the cultural practices, especially when we talk about violence against women, it's also because we have these cultural practices where a woman gets married and has to go and settle into the husband's house with our in-laws, and that itself makes women in a very submissive position, and that's how our autonomy is lost, because we cannot it's we don't feel like we belong to the family, and it takes quite a while to really adjust within that family. So, although there are other forms of gender-based violence that prevail in Nepal, for example, child marriage, girl trafficking, isolation during menstruation, economic deprivation, deprivation of education, lack of autonomy, but still, most of the violence, they occur within private sphere, making women more vulnerable to violence at home. And there are other forms of violence that we found through HERA were more prevalent, for example, reproductive coercion. And the main causes for these, the deep-rooted causes, is actually patriarchal society, gender inequality, and as I've already told, how marriage practices is done, and you know I think now there are lots of cases that we see and that has been reported is of non-consensual sex within marital relationship. And since I've been working with issues on domestic violence, there are lots of women who report domestic violence if they report. And one of the reports, from the World Bank in 2017, they they found out that 149 people were killed due to gender-based violence, and 140 of them were women, and mostly the perpetrators were either husband or in-laws or anyone within the family. And we don't have any forensic data, but as far as I remember, one of the report on maternal mortality in 2000, it stated it had this. It stated explicitly that most of the suicide that occurred during this reproductive age from 15 to 49 years. One of the causes of suicide in that, in the reproductive age of a woman was because of violence within the family, and there was this quote where the women said that she died, where I think it was verbal autopsy, and it was out that she died because her father-in-law had forced her to sex, and she was pregnant with her father-in-law's child, so she had to commit suicide. And the study that we did during my PhD in 2013 to 2018, we found that 21% of women out of 2024 reported any forms of physical, emotional, and sexual violence during, at home and by their spouse and in-laws, and less than 2% experienced physical violence during pregnancy. And although I mean, research on violence against women is in a very nascent stage, and it is like now it is blooming, I must say. It has increased, but these informal reports also suggest that there has been increase in violence due to COVID, uh, where out of three, there's an organization called Women's Rehabilitation Center, which is in our advisory committee as well, HERA's advisory committee. They are one of our stakeholders. They found out that more than 50% of women had experienced violence, and it has increased during the COVID period, and only few had sought for help. And during my PhD, we also found that women endure the burden of violence either due to normalization of violence, culture of silence, um, and maybe economically she was not empowered and she was dependent on the husband's money. So now I'll be talking more about different interventions at different levels, at the government level, um, and then the NGO and INGOs, as far as I know, and then the academia. So the government has, in 2010, the government of Nepal recognized that violence against, that we have to have an action plan to reduce violence against women and girls in Nepal. So it formed a committee, an action plan, where the committee realized and recognized the role of healthcare as one of the sector that was involved in reducing violence against women. So in 2011, they started with the Ministry of Health and Population, started with um, piloting 11 one-stop crisis management center, which is now increased to 73, and now I think in near future we will have 77, covering all the districts in Nepal. So we will have 77 one-stop crisis management center, and through the government sector there are 10 safe houses and one long-term shelter where the women can stay, like a hostel, where she would have livelihood options, livelihood training, skill development, and then she can move out when she thinks that she is able to move out of that shelter. And at the Prime Minister's office we also have gender-based violence relief fund, um, and we have the Department of Police, the National Women Commission. They have helpline where the women can call, and it seems that during COVID, um, there were 4,559 women who sought help, information about GBV, existing legal protections, and also how to access to support system. Although the government has these many interventions in place for reducing violence against women, I think the major gap is the linkage. There's no linkage between the government structure, the works that the NGO does, and academia. So one of my advocacy, since a decade has been, how do we as academicians be a part of the government initiative, and promote this evidence-based interventions to reduce and help women who have experienced violence. So even like NGOs, there are lots and lots of NGOs and INGOs. I'm sure most of you are aware of at least some of the NGOs and INGOs in Nepal who work with on issues related to violence against women. And I think there was one INGO. It's called Equal Access. They had this awareness program. Actually, they did a randomized control trial in partnership with University of Minnesota and Yale University, and it's called Change Starts at Home, which was basically using media and community mobilization to prevent IPV against women and girls in Nepal. So it was centered around a very innovative weekly radio program, and it seemed that this randomized control trial had a really good impact on bringing awareness, and also, one of its objective was, I think, work was also related to how do these husband and wife balance their power, so which seemed to have made an impact on the lives of couples in the working districts that they had their intervention. So I think this is the only randomized controlled trial in terms of community awareness in the context of Nepal. And although there are lots of interventions, at the community level, which is mostly centered to bringing awareness about the rights of women, what is gender-based violence, and all, and campaigning about the helpline, and all the and interventions like these. But but the thing is that in Nepal we really lack research, and lack knowledge around publication of what works and what does not work. So the work mostly remains unpublished. And at the government level, there is this Men Alliance. So the government has also started to think about how do we address masculinity, and what are the interventions related to perpetrators' wellness. Because in our law book, one of the laws says that if the women cannot leave the house, then the man has to leave the house, but it never happens. So they have also started thinking about programs for perpetrator and open jail, but I don't know what it looks like, the open jail. But the discussion, they've started discussion around this open jail as well. So when it comes to academia, I think there are. One is HERA. So maybe Gene is just smiling and putting his thumbs up for HERA. Where we are looking into how do we integrate, link healthcare services and the community informal services to help women, to help healthcare professionals identify and refer, and help these women, assist these women. And if not, how to really, assess danger, and how to assess safety of women, at least for those who do not want to leave. Because it doesn't seem that from our research, from our qualitative research, both at HERA and also from my PhD, it is evident that women living is not the first option that women think of. So living is so I think they would like to take a chance, you know, and in the hope that the perpetrator will change their behavior against them. So in a way, they'll become good with them. So then the other study that is focused is how to educate women on different safety behavior, and that was where I started my PhD. Looking at the feasibility of a flip chart education to women who have experienced domestic violence about the safety behaviors, and most of our work was inspired by the work done by Judith McFarlane in the US. And we actually adapted and modified the safety behaviors to our context, and we assessed the feasibility. And then in the round two, which we have already received funding, we will look at maybe other options of educating women and see whether their self-efficacy will increase, their mental health will improve or not. So that is the other research in place, the intervention research, and that would be a randomized controlled trial. We're thinking of that. So, and then there is a third study done by Sapkota and Diksha Sapkota and her colleagues in Australia, where they have done an intervention on mental health outcomes, and and interventions around how to um, how to elevate stress, and how to educate women what to do when they are stressed, and which also includes some of the safety measures that we used during our advanced study. So in academia, we are really improving our research area, and where the major one of the main aim of HERA is also to develop a research hub within the university. And when Jean talked about our HERA and UNFPA cooperation, UNFPA was actually very interested that we wanted to, develop university as a research hub, and they felt that it is important, very important, to have, collaboration with universities. So they were very open about, collaborating more, but which, because of COVID, I think it is, this collaboration is a bit inactive, but we are still together during our stakeholders meeting, within HERA. So these are the three interventions, and I think the huge gap lies. Although, like, we are doing great job in our own institution, within our own institution, with a little bit of collaboration here and there. But I think the gap is still that, there is no linkage between the government, the NGOs and INGOs, and academia, which really, I mean, I think it's a gap, and it can be seen as a barrier. So I think I'll just leave you with this gaps to ponder, and maybe we can talk more and discuss more during our Q&A session. Thank you very much.
Okay, Poonam, that was really fascinating. Poonam and Jean, thank you very much for those. And I think I'm going to take the chair's prerogative and start with a question, because that was really fascinating. Now, you mentioned how women weren't seeking external support, or there was barriers there or challenges. Can you take us a bit through that across the different countries? Was there contextual differences in that? Or how did that play out?
So perhaps surprisingly, not as much variation as you might expect. So what are we talking about? We're talking about a woman disclosing with, say, to a doctor or to a nurse. And the model for support, at least historically, has been that the sort of expertise around supporting survivors of gender-based violence lies in outside the clinic. It lies in a kind of a focal gender violence center, or lies in the judicial system, but that essentially when we were first conceptualizing the kind of different HERA models, the idea was that we provide a good referral pathway to outside the clinic. But it turned out, and this was already based on early interviews with survivors, as well as observations of what was happening in the early pilots in Palestine and in Sao Paulo in Brazil, was that actually women didn't really want to go outside. And there are various reasons why that was. You know, it may be about your greater visibility as a survivor. If you disclose something in confidence to a doctor or nurse, then going outside makes this visible to your family and to the wider network. And so we kind of morphed then into some kind of not just recognition of that, but that what could be done within the health center itself, and what kind of immediate sort of psychological and advocacy support could be available within the four walls of a health center. And Poonam, is that because I think there's a similar issue in Nepal really as well, isn't there?
Yes, yes, Jean. It's similar. You know, leaving is not the first option that women really think of doing, actually. And I think, yeah, and it has been discussed in our meetings, in our HERA meetings quite often. And I think that is why we thought, you know, healthcare could be one of the structure that where we can identify, refer, and maybe, you know, support them with first line support actually by the healthcare providers. Yeah.
Do you find the healthcare providers are open to that, or is there resource constraints? I mean, how do you feel that's playing out?
It varies, but that, by the way, I think it's really important that we don't essentialize some of this stuff in terms of the global South. I think this is global because
Absolutely.
the work we do in the UK as well, there's a real variation between even doctors and nurses within the same practice, within the same clinic. And that, I mean, I don't want to overgeneralize about HERA, but again, within the various pilot sites, there is an openness. There's certainly an openness to receiving the training and knowledge of how to refer and support. I mean, the proof of the pudding will be how identification and referral for further support actually plays out. And, you know, until we have the data on that, I wouldn't want to be overly kind of optimistic. But I think I mean, again, Poonam, you know, in terms of Nepal, I think there is an openness on the part of the providers you've interviewed and about wanting to be able to respond.
But, you know, thank you very much for bringing this up, because this is a really big issue in all of our research programs, because we have to set up referral systems for women that are being identified as having maybe mental health problems for whatever reason, and knowing that having a kind of external body is not going to help them actually sets us up in how we operationalize certainly some of these large-scale research programs. So thank you for that. That's a really important point. Okay, I'd like to open it up to the audience. Please, do we have any questions?
Yeah, we have one from Sia. Would you like to ask your question in person?
I think we're finding.
Hi there. I'll just repeat what my colleague Gun has said. We have a question from Razia Sultana, who we're delighted to know has been very active on Twitter throughout the webinar. Razia, would you like to go ahead and unmute yourself, maybe use your camera to ask your question, or would you like us to ask it for you? Right, I'm going to go ahead and ask Razia's question on her behalf. She says, are research HERA stakeholders only LMIC members or UK BMEA group also involved? So I think just to paraphrase that, if I may do so with Razia's permission, she's asking if the stakeholders in HERA are only from low and middle income countries, or whether Black and minority ethnic people from the UK are also involved. Thank you.
So the stakeholders are based in each of the in each of the countries, because that concept behind the NIHR funding for this is that the work happens within the global south and not within the UK. Having said that, I lead a research group within the University of Bristol, which does a lot of research around gender-based violence in the UK. And that has very strong links to stakeholders in the UK, including domestic violence national organizations, including organizations that focus on the needs of ethnic minority groups. So in that sense, we have a kind of the voice, the BME voice, within the work that we're doing within the UK.
So we also have a question from Francesca, our colleague Francesca Miliaccio. Hope I've pronounced your name, Francesca. It occurs to me I've never actually said it before. But if you'd like to go ahead and unmute yourself and ask your question, that would be great. Thank you.
Well done, Shireen. You pronounced that perfectly. Thank you. And thank you, both of the speakers, for the amazing presentation. It's actually really hard to limit questions. Sorry, I realize it's the first time I've actually spoken today. I think if I can put thoughts to words, and I'm sorry if this is slightly convoluted, but I wonder if a large part of feeling comfortable to ask for help is knowing that there's going to be some kind of societal response or support, even on the part of the healthcare professional you are speaking to. So I wonder if that has changed anyway, and if the program kind of helps educate and changes governmental and society, the way it kind of faces violence against women. Does that make sense at all? Sorry, that was really...
It makes sense. Poonam, do you want to kick off with thinking about the Nepalese context around that question?
Yeah, yeah. I mean, it's a very tricky question actually for me. If it comes to, when I try to address it, because there are many factors actually that really limits a women's help seeking actually, and I think every women, they are individual, and what we found that for one woman, violence could be hitting, and for the other, just shouting or yelling could be perceived as as serious as anything else. So in that context, I think there are both ways. Firstly, women are not aware about what are the services that a healthcare provides to them. And then there is this gap in communication. And not all healthcare providers are really trained to ask women in a right way. And what we found, talking to these healthcare providers, are that they themselves have been nurtured and brought up in this Nepali culture where they've experienced patriarchy, discrimination themselves. So in a way, even they have sort of normalized, and the only thing that and most of them, they have been doing things to really mediate violence, and they have been doing all sorts, like talking to the perpetrator and the woman, putting the husband and wife together. Without even knowing what is right and what is wrong, but at least they are doing something from their side. So it's I think the way I would respond to your question is, I think we don't know where how to balance this help seeking and also providing help. So probably we thought training the healthcare providers to intervene from the findings from the findings of interviewing women, where they wanted the healthcare providers to ask, training these healthcare providers could bring a sort of balance there. and we used and we are using something where we can transform the healthcare providers' own gender norms and understanding trauma to be able to respond to these women. I think that's what I would say.
And I think in supporting them or
Yes.
helping the healthcare provider ask and feel they're not a voice in the wilderness. So what, I
Yes.
guess what partly Poonam is pointing to is that making it possible for them to ask is also having within the clinic someone who can provide more support than a frontline doctor or nurse can. So thinking about your question, Francesca, in terms of what are the obstacles, well, certainly
Obstacles, yeah.
that's removing one of the obstacles, that it's not all down to you as the doctor. Oh my God, what do I do next? And I've got 8 patients out there waiting to see me. But then what I'm also hearing in your question, and again, Poonam's sort of pointing to it, is what about the wider community context in that is the clinic a voice in the wilderness then? And one things we're beginning to learn in HERA in thinking about future work is how we integrate more the healthcare response with the community perception of not just gender-based violence, but what healthcare can do in relation to gender-based violence, and that, for instance, the clinic may be a safe space to disclose. This is much more ambitious than designing a program within a clinic. It's really thinking about how you work at a community level. So, a kind of landscape opens up a bit of future work that really has to go beyond healthcare and goes back to what you can think of as a community response to gender-based violence.
So actually, hi there. Can I just let you know that we have a question from Humaira Mahmood, who is ready to ask her question. Humaira, if you're ready to go, we're ready to hear you.
Thank you, Shireen. Yeah, hi, Humaira Mahmood. I'm sitting here in Munich, so the LIDC has reached onto the continent. So thank you both, Dr. Rishal and Professor Feder, for today's discussion. This is open, and actually it lends to what Professor Feder, you were saying about the community involvement, and especially Dr. Rishal, when you're talking about Nepal, about the government initiatives having a disconnect to the NGOs and the INGOs and the academics. And I was wondering, what is the collaboration and cooperation like with the religious and community leaders? Because I think in certain societies in the global south, religion, obviously, and community plays a very important part. And one of the reasons why women might fear to talk up is because of the concept of shame. And that shame is perpetuated by the community and the religion. But at the same time, no religion advocates for violence against women. So I was just wondering as to the extent of collaboration with those communities and the religious leadership.
I was looking to you, Poonam, to begin the response.
Well, I mean, it's a good idea because, because shame, as you've said, like shame also comes from this culture of silence, and the culture of silence is also, related to religion, and also, like, as I've already mentioned, how the marriage is practiced, in Nepal, and that is also another thing. But I think, yeah, I mean, that could be a good, I think I'll just be open about this idea, and I would just thank you for, showing us this, but possibly maybe we can do something later in future, and maybe not now, but these are things that needs to be considered, and it's very important.
Thank you. Thank you very much.
Yeah, and
Thank you.
the fact is, it's a big gap in our thinking about how to work with the community response. And as we raise our sights from what's happening within the clinic to what's happening outside the clinic, it's obviously, it's crucial. I actually want to point to someone who's doing this, but not part of HERA, but someone who seems to be an LIDC associate or affiliate, Romina Istrati, who's based at SOAS, School of Oriental and African Studies, who actually is focusing on exactly that question in relation to the Ethiopian and Eritrean Orthodox Church. And her PhD work and her more general work around decolonizing research has really kept it well, is developing a focus on what the role of religious leaders might be in a society-wide response, not necessarily a healthcare response, society-wide response. And I think her work is really pioneering on this. And I think all of us working in the area of gender-based violence need to begin thinking, as I think you're pointing us towards, Humaira, into how we can work together with religious leaders.
Absolutely. I'm thinking that just because you also mentioned the issue of the fact that the women are not, I suppose, so embracing of external referrals. And that's just another way to coalesce that gap. So, but thank you both very much.
Thank you. That was a very insightful question, actually. I had, not thought of that to that extent.
Great. Shireen, do we have other questions from the
I
audience?
have a question, if you wouldn't mind if I start my video and ask it before we go back to the chat. Is that all right? Thank you. So first of all, I was roaring my approval there for for that last question. I thought it was great because I'm half Sierra Leonean and half Lebanese. So it was actually the question I jotted down was about shame. But the other question that I wanted to ask was more or less along the lines of behavior change. So I've just mentioned growing up in Sierra Leone, as you know, we had this terrible Ebola epidemic. And one of the things that really helped to get the message and counteract misinformation as well about Ebola was community theatre troupes that travelled around the country and performed these skits in local languages in villages to get across the message about safe health and how the Ebola disease was spreading. So I wanted to ask about a general question about behavior change and also about the role of the arts in combating gender-based violence. Thank you.
Yeah, I think I would like to respond to this. I mean, it just happened that, it's just a coincidence that you asked this question because tomorrow there's a PhD candidate who is defending his thesis. Actually, he used forum theater to bring awareness and, and also behavior change using forum theater on he started with trafficking actually, but then he then went back to using forum theater to bring awareness on gender-based violence and through skits in Nepal, actually in the eastern part of Nepal. So probably and he really found that it was impactful. So tomorrow we will hear that, and forum theater has been used. So, and even in my work with the Linnaeus University, we are using forum theater to bring awareness on issues related to lesbian, gay, bisexual people and violence against these people. So I think and I have used forum theater also when I was working at Women's Rehabilitation Center. So we have, and these, not only forum theater, but also something like storytelling, these have really made an impact in terms of GBV. So, so this would be something to really expand on later in future, and probably one of the team will be evaluating their use of forum theater so very soon. So but I don't know why we were like, I think, more focused on healthcare because we really found a gap, uh, between help seeking and healthcare. So I think Forum Theatre does it's a wonderful tool to use when it comes to behavior change in the community. So yeah, so we have been using that just to. I can share if he allows, then I can share his thesis. I mean, I can just email Gun and then maybe you can read
Yeah,
it
that'd be
too.
great.
Yeah.
Would send an email to the participants today. I hope my microphone is working better now. I think Francesca has her hand up. Francesca, did you have another question?
Yes, sorry, unless there's someone else that wants to ask something. I'm very cognizant that I've already had my turn. Just a quick question. When you spoke of accessing healthcare, do you find that there's ever, as part of the abuse, a restriction to healthcare and kind of not letting women even be able to get to the clinic? And if so, how are you getting around that?
At least in the context of Nepal, what we found from our Nepal demographic health survey was that women were accessing healthcare more when they were pregnant. So that's why we have sort of thought of integrating our services in the sexual and reproductive health, because that is when antenatal period is one where I think there's more than 80% of women actually access the service, and the other but there's one challenge, and the challenge is that there is this, as I already told, there's disparity in access when it comes, there's a huge divide between rural and urban, especially in the context of Nepal. So access does, I mean there is hindrance there, but at least, and also because of this incentive program, women visit the antenatal care 4 times. So we think could antenatal period could be one of the opportunity, and that is why we want to really make them understand that if somebody inquires and if you disclose about violence, and you will be given information, counseling and stuff, so that this message could be spread in the community. So yeah, and have a larger impact.
And the other context that is child health. So if you bring even if your husband stops you seeking healthcare, bringing the child for a checkup is another place where there's an opportunity. But of course, the other problem is that you may be allowed to get healthcare, but that your husband or your brother-in-law or your mother-in-law is with you the whole time in the consultation. Yeah. And so part of the HERA training is about how we can find ways of for the woman to be on her own with the nurse or with the doctor. So that's part of the kind of consciousness that we're trying to get on the part of the clinician, that you really need to try at some point to be on your own with the woman.
Can I just jump in at this point for those of you who aren't on the chat, because I know I'm often not on chat in webinars, to let you know that Dr. Romina Istrati of SOAS is actually our featured member this month. So if you go to LIDC's website, you will see a quite comprehensive interview that I had the joy of conducting with her before she left for Ethiopia to carry out her research into conjugal violence and the role of faith in that in Ethiopia. So go to lidc.ac.uk. We're also putting the link in the chat. It will be a great chance for you to have a look at what else LIDC does, our podcasts and so on, and take advantage of the opportunity to join LIDC if you haven't done so already. So any other questions, please do go ahead and raise your hand or type in the chat. Otherwise, I will defer back to the chair.
Okay, thank you very much. I think, you know, that was really fascinating. And I think I'm cognizant of time. So I really wanted to ask you, you mentioned about equitable partnerships and how you were trying to transform that across the period of time of HERA. Can you take us through that a little bit, and what are the challenges to that in terms of addressing these power inequities?
Right. I mean, this is, I think, the biggest challenge of these types of collaborations, and I'm sure at LIDC you struggle with this as well. And you know, and this breaks down into some very concrete issues like authorship, like you know, who controls that stage of, you know, setting up a particular research design. Where is the, you know, who chairs the meetings? When there's additional resource that can be levered in, you know, how are those decisions made? And I think that, you know, I'm not saying we've cracked it and that we have, you know, we can produce a manual how to do this properly, but I think so what's happened within HERA, it'd be interesting to hear what Poonam thinks about that. We've tried to become actually conscious of the power imbalance. I mean, for instance, the power imbalance is that there's a lot of expertise of, you know, decades old within the UK researchers, and some of it even, you know, from work in the Global South, and they're bringing that to the table with researchers who, on the whole, and there's an exception to this, in Brazil, we have a very experienced PI in Ana Flavia, who's been in the business as long as I have. We're bringing it to the table and saying, look, here's this expertise, here's this stuff we'd like to teach you or work with you on. And in fact, when you look in detail at what the transactions are, there's a lot of knowledge and expertise which doesn't have quite the same status, but which is coming from our partners, but which, unless you're listening for it and trying to foreground it, gets missed. And it's trying to find ways of actually hearing the different kinds of expertise as well, and rotating the chairing of meetings, and, you know, doing some of the basic mechanics. So that's a pretty not chaotic, well, it's a kind of a chaotic answer, because I've kind of taken various elements and said we're trying to do better on each of them. But Poonam, I mean, you know, two plus years in, what do you think about that direction of travel? Not to put you on the spot.
No, that's okay. I mean, I'm happy to talk about this because I think, you know, even I get all these questions here in Nepal. How are you doing with the relationship with a country, with UK and other countries? I think from the inception, you know, we've been working together, which means that, you know, power and hierarchy was not an issue right from the start. And like, I think my own experience is that, you know, in HERA and the partnership, there's mutual learning. So I think that is a great thing, and that really says that, you know, when Jean says you're putting in front your expertise, is, you know, you get opportunity to really explore your own potentials. So it's not like, oh, Jean has, you know, Jean and Anna, they have like traveled a lot and I've just started, you know, it doesn't feel like that. So and I think yeah, I think that is it. And for any disagreements, I think we discuss. I have never faced disagreements. I think it's just discussion. So so that is something that happens in HERA to really flourish this partnership. Everybody is given an equal opportunity for learning and facilitating learning. Although I always feel that, you know, since English is my second language, I always feel inferior, but when I'm at HERA, I don't feel that. So I think that is something.
Okay, that's an amazing testament to how this research program is being managed. So well done. I'm cognizant that we're really running out of time. Does anybody have any last questions? I'd like to, if we don't have any last questions, Poonam and Jean, you've been absolutely fantastic panelists. Thank you for coming and speaking us today. And we welcome in the future hearing more about what is happening in HERA. Please keep in touch with us. And thank you very much for your contribution. And I'd like to thank the audience for joining us in this really important webinar.
Yeah, thank you for this privilege. Bye. Take care, everyone.
Thank you so much for coming.
Thank you all very much. For those of you still here, if you're in an LIDC member college, we have a decolonization working group. So do link up with us on Twitter and we can connect. We can get you informed on what we're doing. Thank you for attending.
Brilliant. Thank you, Shireen.
Yeah.